Hi, my name is Emily Bauer. I am a transplant and cellular therapy nurse practitioner at the University of Chicago and a DNP student at Maryville University. Today I'm going to discuss a quality improvement project that brought survivorship care plans to hematopoietic cell transplant recipients. We will begin by discussing the problem this project addressed, then we'll review the relevant literature and outline the methods used, and finally we'll reveal the findings and discuss their relevance going forward. Around 60,000 people globally receive stem cell transplants each year, and this number is rising. As more people are transplanted and medical technology improves, patients are living longer after transplant, which is great. But with the extended life comes more complications post-transplant. The Institute of Medicine has recommended that cancer survivors receive survivorship care plans to summarize a patient's cancer diagnosis and treatment history, possible long-term complications, and recommended monitoring guidelines. One system that has been recommended and used successfully at other centers is the use of the electronic medical record, EPIC, at our institution to create survivorship care plans. Despite these recommendations, patients often do not receive survivorship care plans, leading to gaps in recommended screening for long-term complications. Prior to this project, no system for survivorship care plan completion and delivery for transplant recipients existed at my institution. The purpose of this scholarly project was to increase the number of hematopoietic stem cell transplant survivors who were given a survivorship care plan via the implementation of an EMR-based SCP. A secondary aim included improved adherence to guidelines regarding screening for long-term complications of transplant. Hematopoietic cell transplantation, also known as stem cell transplant or bone marrow transplant, refers to a process in which healthy stem cells are obtained from peripheral blood or bone marrow and infused intravenously to replace a patient's stem cells. An allogeneic transplant is one in which the patient receives stem cells obtained from a donor, which you can see here. Hematopoietic stem cells are collected by apheresis or bone marrow harvest. They're processed and cryopreserved. Meanwhile, the patient receives high doses of chemo and/or radiation. Then the donor stem cells are thawed and infused into the recipient, much like a blood transfusion. Sometimes we're unable to find HLA-matched donors for allogeneic transplants. In these cases, we can use mismatched donors with higher levels of immunosuppression or umbilical cord blood, which does not need to be matched as closely. Autologous stem cell transplants are similar, but the donor and the recipient are actually the same person. They don't require immunosuppression for graft versus host disease prophylaxis. A survivorship care plan refers to a thorough summary of the patient's treatment, possible complications, and recommended health-promoting activities and follow-up care. Surveillance includes ongoing monitoring for disease relapse, complications of transplant, and secondary malignancies. This project was guided by a thorough review of the literature. I started my search using Articles Plus, which allowed me to simultaneously search all the databases at the University of Chicago Library. The databases returning most results were EBSCO, PubMed, CINAHL, and ScienceDirect. Limiters and keywords are listed on the slide, and the initial research resulted in over 2,800 articles. After narrowing with Boolean operators, 175 articles remained. I reviewed the abstracts for significance and sorted the literature by theme. 22 articles were included in the final literature review. The themes that emerged from the literature included survivorship care plan format, benefits of survivorship care plan implementation, barriers to survivorship care plan execution, and suggestions for overcoming these barriers. Each of these themes will be examined more closely in coming slides. The literature review revealed that patients and providers have different ideas about which content should be included and how and when survivorship care plans should be delivered. SCP benefits included increased knowledge and understanding, enhanced communication and care coordination, and improved overall health, including mental health, an increased likelihood to adopt health-promoting behaviors such as adherence to nutrition, exercise, and surveillance guidelines. Despite the documented benefits of SCP implementation, many barriers also existed. The most important barrier is lack of resources such as time, personnel, and space. Perceived difficulty in creating and using survivorship care plans, uncertainty about their effectiveness, and lack of institutional support have also been cited as possible hurdles. Insufficient reimbursement for care plan preparation and delivery also means that SCP provision may not be prioritized over more financially profitable activities. Integrating the SCP into an existing EMR has been promoted as one possible solution for overcoming these barriers. Several researchers have demonstrated that utilizing the EMR to develop and deliver SCPs is a feasible strategy that works best when policies are present and staff is trained to be aware of their respective roles. This literature review provided sufficient information to support the creation of an EMR-based SCP. Each author based their research on current literature, and most investigators, describe their inclusion and exclusion criteria, recruitment technique, and/or demographic information, enhancing reproducibility and assessment of generalizability. There are also several notable weaknesses in the literature. First, many were pilot programs involving small sample sizes at single cancer centers. Many were using voluntary surveys, which may be subject to selection bias. Additionally, there was a significant lack of racial and ethnic diversity among the participants, and most of the literature focuses on survivors of solid tumors. All these factors limit generalizability to a more diverse transplant population. Only 3 of the 22 articles were randomized controlled trials. Similarly, there was little research on SCP utilization within the transplant population. 17 of those 22 articles were focused on SCP use for solid tumor rather than transplant survivors. This project was guided by the Cancer Survivorship Care Quality Framework. This model describes 5 domains of cancer survivorship quality, which focus on prevention and surveillance for cancer recurrence or development of new cancers, surveillance and management of physical and psychosocial effects and chronic medical conditions, and health promotion and disease prevention. This model also considers a patient's contextual and individual factors to promote positive survivorship outcomes. Methods for project completion will be discussed next. There were few risks involved in this project. One possible risk was breach of confidentiality. However, this risk was minimized by upholding the HIPAA privacy rule. The project was also approved by the IRB at Maryville University and the local medical center prior to implementation, and I have no conflicts of interest to disclose. The project took place in a large urban academic center in the Midwest region of the United States, responsible for over 300 hematopoietic stem cell transplants between 2017 and 2018. The Outpatient Oncology Center, where the visits took place, completes nearly 50,000 patient encounters annually. The inclusion was limited to adult patients who received transplants and had benchmark days that fell between February 1st and July 31st, 2021. Patients must have been active at the transplant center, and they must have been managing their care as an outpatient for at least 7 days. Records were not included if the patient had relapsed disease, was admitted to the hospital, or had been enrolled in hospice. The recruitment process is summarized in the figure on the right. A transplant-specific SCP template was created in the EMR. The multidisciplinary team was educated about their role in creating survivorship care plans and adhering to surveillance guidelines, and patients were identified using the transplant patient database or by provider referral. After scheduling, SCP creation was initiated in the EMR. The patient confirmed their oncologic diagnosis and treatment history, participated in a survivorship-focused review of systems, learning about possible long-term complications, including signs and symptoms, screening recommendations, and preventative measures, and received a printed and/or electronic copy of the survivorship care plan at the completion of the visit. The patient's primary care and oncology teams also received electronic copies of the care plan and a summary of recommendations for specialty referrals and surveillance testing going forward. Following the 12-week pilot period, a quantitative exploratory design through retrospective chart review was utilized to evaluate the project's success. The data on the left was collected from EMRs and stored in an Excel file on a password-protected and encrypted drive. A data collection plan table, part of which is seen on the right, lists variables that were analyzed and describes how each was coded. SPSS was used to evaluate the descriptive statistics using measures of frequency and central tendency. Additionally, these data were evaluated for baseline similarity between groups by running chi-square and Fisher's exact tests for nominal level data and independent samples t-tests and for scale level data. Due to unequal sample sizes in the pre- and post-intervention groups, z-tests were calculated using Microsoft Excel with the help of Dr. Pauls, Maryville's statistician, to determine whether there were significant improvements in SCP receipt and/or in adherence to surveillance guidelines following the intervention. The methods of evaluating SCP receipt and adherence to surveillance guidelines were deemed by 3 persons to have faced validity. Clearly defining variables prior to data collection enhanced intra-rater reliability, while employing a single data collector eliminates concerns about inter-rater reliability. Next, we'll review the project's findings. This sample consisted of 102 EMRs, 56 in the pre-intervention group and 46 in the post-intervention group. The mean age was about 55 years. Most of the patients were white and male. There were no statistically significant differences between the pre- and post-intervention groups for baseline characteristics of sex, race, transplant indication, or donor type. On average, patients were approximately 1 year post-transplant. The post-intervention group was farther out from transplant than the pre-intervention group. The differences between the pre- and post-intervention groups was significantly different for benchmark visit type, with a p-value of 0.005. Both groups had positively skewed distribution for number of days post-transplant. The post-intervention group had a significant outlier, with one patient 3,982 days from transplant, but a two-tailed independent samples t-test revealed no statistically significant difference between the mean number of days post-transplant in the pre- and post-intervention groups. However, the pre- and post-intervention groups were significantly different for baseline characteristic of graft versus host disease presence and type. The column on the far right summarizes the total graft versus host disease in each group. And the significance was a p-value of 0.001. Overall, there was a significant improvement in SCP receipt following the intervention, with a p-value of less than 0.001. With a rise from 0% SCP prior to the intervention to 65.2% SCP receipt following the intervention. However, the overall improvement in SCP receipt was not sufficient to meet the Commission on Cancer recommendation of 75% receipt. Although improvements were made in adherence to surveillance testing on 9 of 18 items, an upper tail z-test for the difference of two proportions determined that there was no significant difference in overall adherence to recommended surveillance guidelines following the intervention. Next, we'll discuss the data's strengths and weaknesses and this project's implications for the future. The completion of pre- and post-hoc power analyses strengthen the validity of the results. Although no data was specifically collected to measure the patient and provider satisfaction with this pilot program, several patients and providers volunteered these quotes, hinting at a high level of satisfaction with the survivorship care program and the care plan. Differences in underlying disease, transplant type, GVHD incidence, and benchmark visit may have impacted results. Allogeneic transplants require additional surveillance, especially when GVHD is present. Decreased transplant volume and COVID-19 related deaths result in a smaller than anticipated sample size, and the small sample and effect sizes led to weakly powered studies. Finally, providers referred patients for survivorship visits but did not attempt to use the EMR-based care plan themselves. So all of the patients attending a survivorship visit received a care plan. So the construct of SCP receipt didn't really measure what it was intended to measure. The SCP was introduced simultaneously with an opportunity for providers to refer patients to a dedicated survivorship-focused visit. None of the providers requesting the survivorship visit opted to create the care plan themselves. However, it seems that the limitation for other providers was the lack of time and/or support personnel rather than interest, because the providers referred more patients for a survivorship care plan to the clinic than the clinic could accommodate. Relatedly, all the patients who attended their survivorship-focused visit received a care plan. So the rate of SCP receipt is really more reflective of rates of survivorship visit attendance. The pie chart illustrates that the 30 participants who attended their survivorship visits all received a survivorship care plan, while the 16 patients who canceled or did not attend their appointments did not. One method that was used to encourage participation in survivorship visits was allowing the patient to choose whether the visit was conducted in person or virtually using video conferencing technology, much like Zoom. Despite this effort, the no-show rate during this pilot period was 21.7%. That's only slightly better than the national oncology no-show average of 25%. However, the difference was not statistically significant. This difference was not statistically significant, a greater proportion of the patients scheduled for virtual visits received SCPs than those who were scheduled for in-person visits. It's possible that the visit type may have impacted the results of this pilot program. While there's an abundance of literature examining SCP use in the solid tumor population, little data is known about SCPs in the transplant population. No randomized controlled trials have been conducted examining a potential relationship between SCPs and adherence to surveillance guidelines among transplant recipients. Many more well-powered randomized controlled trials examining the potential benefits of SCPs in the HCT population are needed before conclusions can be drawn about SCP utility for transplant survivors. Research testing possible methods of eliminating some of the identified barriers to SCP creation, particularly the time commitment involved, would be beneficial. As clinicians and educators, nurses and nurse practitioners are perfectly suited to create and review SCPs with transplant survivors, contributing to enhanced communication and improved outcomes. Reducing no-show rates using telephone calls, text messages, or a combination has the potential to improve SCP receipt, and future quality improvement efforts should focus on minimizing barriers to SCP creation and delivery. The COC's updated accreditation requirements, which will go into effect in January, state that an institutional policy describing how services are delivered within its network must specify how services are coordinated between a central entity and satellite sites. Written policies describing who should receive an SCP, what information should be contained in it, and how frequently survivorship visits should occur are needed. Nationally, policies guiding insurance reimbursement for survivorship services are in flux. Some centers are participating in bundled service reimbursement through the oncology care model. Additionally, several bills have been proposed, but not yet passed, to ensure Medicare and Medicaid reimbursement for survivorship services. Conversations regarding the ongoing feasibility of this survivorship care model continue between providers like myself and the administration at my institution. Hospital administration fully supported the pilot, but's now asking for a detailed cost analysis to determine whether contributing to pay personnel to complete these survivorship visits will be financially viable. In conclusion, the project successfully demonstrated that survivorship-focused visits resulting in the delivery of a personalized survivorship care plan is feasible but time-consuming and therefore costly. The project did not achieve the COC standard of SCP delivery of the 75% SCP delivery or see a correlation between SCP receipt and adherence to surveillance guidelines. Small sample and effect sizes and the project's short time frame limit the generalizability of these results. Future quality improvement efforts should focus on minimizing the barriers to SCP creation and delivery, and future research should prioritize large randomized controlled trials investigating the effects of SCP use in the transplant population. Here are my many references. Thank you all for listening. I really enjoyed following everyone's projects. A special thanks to Dr. Sandheinrich, my chair, for her guidance. And if you're interested in becoming a stem cell donor, please visit bethematch.org. It's a super easy, painless process, just a cheek swab. Thanks again.